Thank you. James Davis.
Thank you, Chair. Professor Peter Johnson first. Turning back to the importance of early diagnosis of cancer, which is arguably the most important area we need to tackle as a country. You gave a statistic before of 18%, I think, that were of cases that are diagnosed on an urgent basis, an emergency presentation. Can you give us an idea of other routes to diagnosis and the percentages involved, whether it's urgent or routine referrals, screening or other sources, and the direction in which that's been going, how much success we've been having in recent years in changing those figures?
Sure. The exact figures I can write to you with, but in essence, as we've prioritised the urgent cancer referral pathway and lowered the thresholds for primary care workers to refer people in, so our 2-week wait pathway, the urgent referral pathway, accounts for around about 40% of cancer that we see, and that's progressively increased over the last few years as we've seen more and more people through that route. And the corollary of that is, as I say, that we've seen a reduction in the proportion of people presenting as an emergency, either in casualty or an urgent outpatient referral. That's down to about 18%. Screening accounts for a very much lower proportion of total cancer pickup rates. I think it's of the order of 5 to 10%. I can come back to you with the exact figure. And the remainder of referrals come in through a variety of different routes and often picked up in other parts of the health service, in hospital, people coming in with a chest infection, for example, who are then found to have a lung cancer and things like that. So that's the general makeup. And overall, we have, by virtue of hugely increasing the number of people we see on urgent referral pathways, managed to drive down the number of emergency presentations, and that has to be good, because we know that the likelihood of surviving cancer is much better if you're picked up through that 2-week wait pathway than if you present as an emergency.
And just to reiterate earlier statements, it's too early to say what impact the pandemic has had on those proportions.
We saw a transient increase in the proportion that we saw as emergencies during the height of the pandemic, but that's now come back down again to, as I say, about 18%. What dropped off was the urgent referrals particularly during the first wave, but again, those have come back up very rapidly. And as I said, in March, I think we saw just over 230,000 people on a 2-week wait referral pathway, which is the highest number we've ever seen.
And is there regional variation which hides particularly good performance or particularly bad performance on a national level?
We do see variations. To be honest, it varies from tumour type to tumour type and across areas. And as the last year has gone by, as the coronavirus has put pressure on different systems at different times, so we've seen fluctuations as things came under more pressure. And I think the public were incredibly sophisticated in the way they adapted to what was happening by protecting the NHS and not going to see their GPs when things were really bad. And then as the pressure came off, we started to see them coming back. So it has fluctuated quite a lot.
Mm-hmm. Thank you. Dame Cally, what's being done to improve the referral process via GPs, particularly in light of the impact of the pandemic?
Thank you very much. So we were doing work pre-pandemic, which we've accelerated during the pandemic to completely review with our primary care colleagues these rapid diagnostic pathways. And the origin of those was really the sort of breast one-stop shop clinics where you wrap the tests around a patient rather than sending them off in a linear fashion for different tests at different times. So we've accelerated the rapid diagnostic centre pathways, both for cancers with specific signs and symptoms, and then very importantly, for cancers with serious but non-specific signs and symptoms, which are the areas where traditionally patients have bounced around in the system too much. Mm-hmm. So we've accelerated the RDC pathways. We are working closely with primary care colleagues to look at how we manage case finding and fast onward transmission. We've just invested, I think Peter alluded to it earlier, 20 million from the Elective Recovery Fund in things like cancer hotlines, so that there is a rapid response if people are worried about a sign or symptom. And then we're also accelerating the lung health checks. So this is the sort of low-dose CT in supermarket car parks is one of the models, but that's to pick up patients at an earlier stage. So there's a lot of work going on with primary care to try and make sure we handle that front end of the pathway effectively.
Very good. But if up to a quarter of cancer cases arise from routine referrals, which I think is true, are you concerned about the fact that waits for routine outpatient appointments are much higher than they were? I mean, I worked as a GP in recent days, admittedly in Wales, but people were being told of a 2-year wait for a routine outpatient gynae appointment. That's really bad news, isn't it?
It's very important that that the whole push is giving the public confidence and to come forward if they have a worrying sign or symptom, and then making sure. So what we're doing with each of the cancer providers via the 22 cancer alliances nationally is it sounds a bit administrative, but it's important, very careful activity and capacity planning. So we've done a lot of work to look at what's required by surgery, by cancer type in each area, and to make sure that the right plans are in place, and that there is a navigation of those patients successfully through the diagnostic and treatment pathway, so they're not waiting. So we're putting additional investment into things like whole pathway navigation. That's really important to sort of pick up any deficits. So we're not seeing, I haven't flagged in any of those capacity plans and in the feedback particular issues with routine appointments amongst the cancer alliances in England. There will be individual issues, because there always are, but that isn't a sort of major concern at the moment. What we obviously need to ensure is that trajectory of more increased referrals, speed with which people are seen, and from March to May, 95% were seen and had were seen within that sort of and had the treatment within that 31-day window. We just need to make absolutely certain that that performance is maintained through the year.
Thank you. And finally, from me, do you have concerns over the number of appointments with GPs which are still being carried out over the telephone or remotely as opposed to face-to-face, and how that's going to impact on referral rates?
Thank you. Very, very important, well, as you'll know, but very important for effective cancer diagnosis. Sometimes, well, it's very important to have face-to-face when that's required. I think we're currently running at around 55% virtual. I think that's correct, Peter. I think that's the correct current position on virtual appointments as opposed to face-to-face. Peter and I are very keen to make sure there's adequate face-to-face provision, because I'm sure you know this, but quite often there's just something can be picked up face-to-face through very experienced GP and patient contact that you can't quite get virtually. It's not quite the same. So we're obviously working with GP primary care colleagues to just make sure there's sufficient face-to-face access for patients with signs and symptoms. As I said, a lot of work going on referral routes in and the rapid diagnostic centre pathways. So face-to-face is important for cancer patients.
Thank you.